As you're joining, please feel free to insert your name and affiliation in the chat. We would love to hear where our participants are coming from. Thanks everybody for joining us today, and welcome to our June Hepatitis B Echo session. My name's Catherine Freeland, and I'm the Associate Director of Public Health Research at the Hepatitis B Foundation. Today we have a really exciting session for today. We'll be talking about all things perinatal hepatitis B, and we're honored to have Dr. Calvin Pan here today, who's certainly an expert on the subject. Before I jump in, I just have a quick announcement. If you're able and if you're a service provider, we're doing a hepatitis delta assessment project, trying to understand barriers and facilitators to hepatitis delta testing for providers. If you have time and are willing to complete the survey, I have just put it in the chat box. Please feel free to complete that for us. It would be of great help, and so we can better understand and really just document challenges associated with hepatitis delta testing. And definitely appreciate your help and support in that. And then also, before we jump in, I want to introduce our team of advisors. I'll start with our Hep B Foundation team, and Anusha, if you would like to introduce yourself quickly.
Hi, everyone. I'm Anusha. I'm the Public Health Program Coordinator with the Hepatitis B Foundation, and I work in our affiliate office.
Thank you so much. And Florence?
Hello, my name is Florence. I'm the Public Health Coordinator in the affiliate office too.
Great. If you have any technical difficulties during the session, feel free to reach out to Florence and Anusha, and they can support you in whatever challenges you might be experiencing. And then I'll turn it over to our provider advisors, starting with Dr. Torgerson.
Hi, good afternoon, everyone. I'm Jessie Torgerson. I'm an infectious disease physician at the University of Pennsylvania and excited to join today's session.
Great. And Dr. Finkel.
Hi, everyone, and thanks, Dr. Pan, for coming. John Finkel, I'm a transplant hepatologist at Jefferson in Philadelphia.
Great. Thanks so much to our advisors. And now I'm going to hand it over to Dr. Pan, who is a clinical professor in the Department of Medicine at the NYU School of Medicine, and he'll be giving the didactic session for today on perinatal hepatitis B. Welcome, Dr. Pan, and thanks for being here. We'll hand it over to you.
Thank you so much. Can I share the slides?
Yes, please feel free.
Okay. So thank you again for taking out your time from your busy schedule and join us to discuss the hepatitis B during pregnancy, how to prevent the vertical transmission from mother to child of hepatitis B virus. So today, I would just have about 10 to 15 slides. I'd like to set the stage for discussion and try to present some of the most recent data in this subspecial subpopulation. So as you know, mother-to-child transmission or hepatitis B infection during pregnancy remain a very challenging question in your clinical setting. Many mothers came into their physician's practice very nervous and wonder where they can get started and how they can get through during the pregnancy, particularly the fear of transmitting the virus to the baby. Now, before we get started diving into the subject, I want to show you some of the new data that just came out a couple of months ago in the American Association for the Study of Liver Diseases. In this meeting, they actually present the most recent data of where the hepatitis B infection coming from in the United States. As you can see here, majority of Hep B infection, they are Asian patients, actually they are immigrants. And why they got hepatitis B? Actually, that was mainly from the vertical transmission, mother-to-child transmission. Among all the Asians, Chinese, Vietnamese, and Philippines, they make up the top three. Now, why is so important when the young child or infants got exposed to HPV? From this data, pretty old, but it's still addressed the major mechanism of chronic hepatitis B infection, which is early exposure during the pregnancy or early age from birth to first year actually have a higher risk to get into the chronic infection. So in adult population, actually after the exposure is less than 10% of those patients will develop chronic infection. But because the young children or infants, they would not have the immune reaction or develop mature immune mechanism to create a virus. That's why they got into the chronic stage easily. Approximately 90% of them after exposure, without any prevention method, they would develop chronic hepatitis B in the first year. Now, I want to mention the most recent CDC guideline actually came out about 3 months ago. Now, focus on viral hepatitis B elimination or prevention. CDC now actually recommend they abandon the at-risk model to screen patients. Before, we always ask patients, where were you born and do you have any risk behavior? But now, no. It's a universal screening policy. That means every patient should get screened. It doesn't matter if they have risk or not. Every adult patient from age 18 to 65, but even older than 65, they still recommend screen. The mandated 18 to 65 have at least once lifetime screening. So therefore, we can have a better chance to identify patient and link them to the care. Now, that has an impact on perinatal care. Before, all the women have babies or they got pregnant, they will get screened. But now even the baby born, it doesn't matter whether they have the record of vaccine or not, they should get at least one lifetime screening. So the other association guidelines have been updated. The most recent WHO guideline probably will come up next couple of months. As far as I know, they also adopt the universal screening policy. And I'm working with another group in AASLD. The new HPV guideline we endorse. I can tell you, even though it's not public, we endorse the CDC universal screening. So let's talk a little bit about if you screen a pregnant woman, the mother have hepatitis B infection, now what we should do, how we can handle it in the way that we can block the transmission. Now, what would be the risk of getting the infection for their baby? Now, we know that in developed country, in the United States or Canada, we have a universal vaccination. And also for hepatitis B infected mother, will give their baby HB, that's hepatitis B immunoglobulin. That's called a passive immunoprophylaxis. So for any Hep B mothers, we give active vaccine and passive immunoglobulin. However, for the last 2 decades, what we know about this topic is some infants, even they receive both prophylaxis, they still get infected. Approximately 10 to 20% of time, they will break through the immunoprophylaxis. So this table actually highlights different viral load, maternal viral load can dictate the HPV infection rate for their infants in terms of how you can prevent it with vaccine versus vaccine plus HB, or even interval treatment therapy that we're going to touch upon in the last couple of slides. So bottom line here is, if the maternal viremia level more than 200,000 international unit, chances are without antiviral therapy, they will have about 10% breakthrough of what we usually do in the hospital is just give the HB and vaccine. Now, if the mother have much lower viral load, which is 20,000, oftentimes, if you're familiar with hepatitis B, many patients may have E antigen positive or E antigen negative. the e antigen negative usually have the viral lower than that. So actually the vaccine could be good enough without HB. So you won't get surprised in developing world or in Africa, if you could provide universal vaccine, actually can save most of the babies born from e antigen negative mothers. But here in the United States, what we need to remember or what we need to pay attention to would be the 200,000 IU. So every mother, when they test surface antigen positive, the next thing you want to approach them is ask them to get the HPV DNA done. In more than 200,000, whatever routine used in the hospital is not going to help to be 100% protect the baby. And we need to start antiviral therapy as early as possible. Now the idea is moving to even the second trimester for those babies for those mothers that have more virus, higher virus level, even like 7 logs or 8 logs. Now this is the most important study in the mother-to-child transmission field. That's done in China, a large case control study. They look at different virus level, maternal viremia level, and the impact of transmitting the disease. So this data actually showing you here on the right lower corner, and seeing that if the maternal viral less than 200,000 IU, there was no breakthrough, zero breakthrough for the vaccine or immunoglobulin. So with that, many antiviral therapy studies have been done between 2010 and 2015, but failed to prove the antiviral therapy actually work to prevent those mothers that have high level of viremia. Now in 2006, there is a randomized control trial in China, enrolled more than 200 mothers and have about 170 infants finished the study. They used tenofovir during the 3rd trimester for mothers at 200,000 IU versus placebo. And here showing you that the right upper side of viremia level get dropped down to below 200,000 IU, 90% of time at delivery, and subsequently translated to the effect of blocking the mother-to-child transmission 100% on per protocol analysis, and even ITT would be at least 3-fold reduction on the transmission rate. So this one actually established now the standard of care for mothers that have a high level of viremia should get antiviral treatment. But you may ask, besides tenofovir, TDF, what are the other antiviral therapy that could effectively block the transmission? Now, this one is probably the largest study using talpividine and amivudine. I know in the United States, we don't use that anymore. It's not a first line, but in case you want to know what else could be effective, that include the other 2 antivirals. They're both category B and could be used for pregnant mother. So lastly, if any mothers ask you what might be the safety concern if I would subscribe to the idea taking antiviral treatment during pregnancy. Now this is the large database, mainly for HIV, but some HPV patients also registered here called Antiretroviral Pregnancy Registry. And here shows you that besides TDF, now another version of TDF with less side effect, called TAF, also have some patients have been tried on. But I know if you are infectious disease, you're like Dr. Tegerson probably have been using that for HIV mothers big time. So, but HPV now have more than 300 mothers using it. That absolutely could be another option, but we require more data on HPV. So now if you want to block mother-to-child transmission, basically for antiviral, we show you the first 3 It's TDF, taupiravir, lamivudine, and now the TAF, even though we need more data, but it seems like could be in the future another option. Now, before I end this presentation, I want to show you the algorithm or the proposed procedure how we should manage HPV mothers and their baby. You start with maternal screening for HPV. Now it's CDC universal screening policy. It's easy to do, regardless whoever adult patient you should screen. Then if it's negative, then you should consider provide vaccine. Even during pregnancy, vaccine is safe in case they don't have immunity. Now, if Hep B is positive, that means they got infected. The next step, you need to determine the viral load and see if they need additional prevention method. You don't want to miss the window period during pregnancy, and then it's too late when the baby is born. Now, after deliver the baby, you should give HBEC and vaccine within 12 hours, prefer within 6 hours. Now, some studies have shown that the early providing the immunoprophylaxis may work better. Then you should follow this baby and finish the hepatitis B vaccine. Oftentimes here is the first month old and then 6 months. Then you should pass the immunity, or if you're successfully blocking the vertical transmission, between 6 months and 12 months. So that's pretty much the algorithm or the follow-up procedure. Now, in terms of mother, what if the mother have HPV DNA more than 20,000 IU? Then you should at least start the antiviral treatment at the third trimester, early trimester. That means 28 weeks of pregnancy. Well, consider some mothers, they may deliver their baby earlier, sometimes premature born. So for mothers with high level of viremia, many studies actually suggest that you should do it during the early or in the middle of second trimester. We're talking about 20 to 24 weeks of pregnancy if the maternal viral load is like more than 8 logs, because you need at least 16 weeks to drop the viremia level below 200,000 IU. So I guess with that, I would conclude my presentation, and I'm looking forward to your case or the discussion, your comments. Thank you.
Thank you. This is super helpful. Thank you so much for your presentation. I think we do have a couple of questions, and I know there were a couple of colleagues that are perinatal Hep B coordinators around the country that actually sent in questions that aren't able to be here, but will plan to watch the recording when we send it out. One coordinator from Colorado was asking about confirmatory testing for hepatitis B. Can you just talk a little bit about that and what the standard of care is? I know you mentioned this briefly in the presentation, but I think really just making sure that it's very clear, like what steps providers should be taking, particularly if a woman does test positive for surface antigen.
That's a great question. I guess I try to answer this question from 2 angles. One is as a screening part, right? And another part is, when it's positive, what you would like to do in this situation. Now, timing is crucial because a baby cannot wait. So you probably should screen using your first opportunity to screen. Whenever the mom show up in your clinic, the first test you want to do is a hepatitis B screening. Of course, mother might have the other medical issues. So timing, I recommend that first opportunity to screen. I know some of the undocumented patients, sometimes they show up late, but regardless, first opportunity to screen. If it's negative, then you probably don't need to do rescreening, because in US, if you use commercial lab or hospital lab, the false negative chance is pretty low. I don't necessarily recommend rescreening for that unless you have inconsistent result compared to the past, right? Or the report coming back doesn't make sense. For example, is surface antigen negative, but E antigen positive, right? So you have some inconsistent, don't have a good explanation, then I probably would rescreen and with the HBV DNA test, because there is a very small percentage of patients so-called occult hepatitis B infection. Their marker, protein markers may not be consistent, showing like the pattern of infection. Now, if you confirm this is absolutely infected, then you should call the patient immediately and perform the HBV DNA test. Because the early you make a diagnosis or determination whether the patient needs antiviral therapy, you will be in the winning side. You would follow up this patient more closely, and most guidelines now recommend that somewhere between 24 weeks to 28 weeks of pregnancy, you should start. Not later than 30 or 32. 32 probably too late for high viral load. So that's what I would recommend you to do.
Thank you. And then for the pregnant persons after they deliver, do you have recommendations on what should happen regarding, especially if they had that 200,000 DNA, what is the next step for that person? Do they stay on treatment? What might that look like?
Yeah, that's another great question. I don't think that a lot of data give you a great answer. The reason is we just went through the WHO guidelines writing group. We have a great discussion. They are going to recommend expanding the treatment indication. Now, China is the first guideline that expand to all treated if a patient age over 30, any DNA. They just treat, okay? Now, I understand American Association for the Study of Liver Disease. Our association is very evidence-based. You know, they're very strict. They're going to do the pickle questions, evaluate the grading of the. Just you know, make the long story short. I don't see with the current literature that you could treat everybody if you're strictly talking about evidence-based. So chances are, the guideline, I mean, I'm leading the guideline, but it won't come out until next year, a second half. So the data that I know, the writing process, we know, chances are those mothers, maybe a small portion of them, it doesn't matter how liberal the guideline would be, they couldn't fit in the treatment criteria, particularly if they age younger than 30, they have no liver damage, they only have the virus, they have no other risk factors. You probably couldn't find a great evidence that you're treating them at this point. Then what you would do for mothers who still have high level of viremia, then either you need to monitor them or it's very tricky. Now, some guideline said if patient wants to be treated, the provider should treat them. So I think there is a missed message, but as a practitioner, I also see a lot of patients. And here's how I approach. Okay, if you get confused by guideline is not a great thing, you know, for hepatitis B practice, to be honest with you. There are a lot of gray zones, complicated. But I will share my practical experience. I'll look at the mother, I'll ask the mother, do you want a second baby soon? All right. If they do, then they have two choices. There are some choices that you can do a short-term interferon treatment. Maybe you can stabilize the viremia, even though they're not 100% well, get rid of Hep B. Then the second or the third, the subsequent pregnancy, they may not have to go through that much tortures and go through all the testing and treating and viral therapy and monitoring. If you can drop the HBV DNA below 200,000 IU, I think it would be great. Reduce the risk. But if they don't want to be treated, then you can just monitor them. Like any other happy patients, as soon as they deliver the baby, your job is try to focus on the modest disease if the disease need to be treated. Whatever guideline you want to follow, that's fine with me, and see if they fit in the criteria. But I would be more proactively treating them if they want to be treated, because I think if there is no downside of treating them.
Thank you. That's super helpful. And then just the last question, then I'll hand it over to Dr. Finkel for his question. If somebody is negative for surface antigen, do they still need HBIG, or would they just get the birth dose, or do you have a recommendation for what would be needed for a person negative for surface antigen, a pregnant person?
Let me see if I can get the question correct. You mean surface antigen negative is the mother, right? Not
Correct.
the baby.
Correct.
So if the mother have no HPV infection, the baby still need vaccine as a primary prevention for their future, right? Vaccine is everybody. It's a universal recommendation globally. Even in a poor country, they don't have the resource. They'll get a free vaccine from a World Bank called Gavi, and so they donated free vaccine. So vaccine is a must, regardless of the mother's status. Now, if a surface antigen positive, then in the US or North America, we have the medical resource. We usually give both. Any surface antigen will give vaccine plus HBIG. But to be honest, I just show you one slide, in slide A, and showing you that for antigen negative mother, the vaccine is good enough. Great. So I think we're overkill. But what it is what it is. You know, it's just another good thing about that is they simplify the procedure, right? So in the hospital, you know, in the middle of the night, you deliver a baby, you don't have to remember, oh, this one get vaccine, that one get both. You just give. It's simplified. That's where we are now.
Thank you. Super helpful. Dr. Finkel, you have your hand up?
Yeah, thank you. So thanks so much for that presentation. I think one of the reasons that we sought you out for this series was that based on a presentation you did at the liver meeting this past year about your newer research looking at starting antivirals earlier and eliminating HBIG in a Chinese population. Could you speak at all about that, or is it still premature to incorporate that into your algorithm here?
Well, thank you for bringing that up. Let me just give the audiences a little bit background so they won't get lost on this. So now, after the New England Journal published the TDF trial in 2006, and we're very excited, and WHO estimate that it will, with the current algorithm, it will save about 3 million infections globally, you know. So, however, in 2017, WHO team, I served as a consultant, they talked to me and said, well, the algorithm is good now if you can practically implement them. But during the implementation, they see a great challenge because many countries, developing area, their government would not subscribe or have a budget to buy immunoglobulin. And also there's a cold chain issues. It's hard to shift the immunoglobulin to the remote area. So the scientific, not that much a scientific question, but rather than an implementation requirement that we can, the question is, can we simplify the prevention algorithm for this high level viremic mothers, get rid of HBIG and just give vaccine? So we designed a study, randomized 280 mothers with high-level viremia. One group get the standard treatment now. What we have here is the HBIG vaccine and plus third trimester TDF. Then we have an experimental arm, which is started with much earlier. That's a 16 gestational week of 16. Use TDF, then our idea is no virus, no transmission, right? We suppress the virus very low. Then the baby only receive vaccine. So I think this study actually showing a non-inferior to the current standard treatment, only about ITT analysis as less than 1% transmission, and per protocol is 100% protection. So I think it has a global implication. But after my presentation in the liver meeting, I also heard some colleagues from North America and said that, wow, it's a great study, but I'm not sure how this one will enhance what we're doing in North America because we have HBA. Perhaps we can save some financial resource or the baby get less pain. So it's still subject to, I guess, cost-effective analysis in North America, but definitely WHO look at the global situation is 85% of the countries, they don't have HBV. So if you want to eliminate hepatitis globally, this is the most important step.
Thank you so much. I was just going to add that I think as we move more toward the treatment algorithm you mentioned that China has endorsed with treating more patients regardless of the current treatment algorithm. I do wonder if you could extrapolate the under 30 population of pregnant women to be in that group, where if they're already on antivirals, you probably just get away with the vaccine and prevent a lot of transmission. That would be the next study you could pursue after this one. People coming in already on TDF or a similar drug as they get pregnant. Just when you see this super high viral load, this is going to take a really long time to suppress those patients, and one trimester is not enough usually to fully suppress them.
Yeah, I 100% with you, Jonathan. I think one of the convenient approach is if we can expand the treatment indication up to 30-year-old. If 30-year-old, everybody get treated if they have virus. So the Panama model would not necessarily need to switch the treatment approach after delivery. Still TDF is a first-line treatment for both mothers and for prevention of vertical transmission and treating the maternal disease. So I can imagine that if after the AASLD can have a guideline come out with a similar recommendation, I can visualize in the future the mothers who need mother-to-child transmission prevention taking TDF, they would just continue it after they deliver the baby and treat their maternal disease after that. But I guess, sooner or later, we'll get to that step anyway, because I like to think about the disease as infectious disease. Some of my colleagues still thinking that liver got to be damaged before you treat it. But if you want to global elimination of viral hepatitis, you have to treat it like HIV, right? I mean, years ago, we look at CD4 count, and now it's the history.
Yeah, really good points. Thank you. It looks like we have a question in the chat as well. So it sounds like, if I'm understanding this question correctly, if a woman during during her pregnancy is within that threshold of treatment, should she continue if she's still meeting that inclusion criteria for treatment, I think, beyond her pregnancy?
Let me try to understand this correctly. So you're saying the question is the maternal disease require antiviral treatment.
Right.
Now, the mother-to-child transmission criteria for antiviral treatment have different threshold, right? So we use a 200,000 IU. Now, let me try to pay this in two scenarios. One is if the maternal disease require treatment, and also the mother-to-child transmission criteria also met. So that means currently you have active disease. The mother might have fibrosis at stage 2 or 3. Nowadays, by the way, many of you probably have been using FibroScan non-invasive to assess the mothers. I have no problem with that, but I think we need more data. I definitely believe that the normal value or the range is different because, pregnancy, actually, they enhance the blood flow to the liver. So I'm in the middle of working on a cohort and try to establish what's the difference. But it doesn't prevent you to use a non-invasive to estimate, but just interpret it with proportion. The end, if the mother has maternal disease and also the requirement for mother-to-child transmission, that's easy done. You just provide antiviral treatment. Now, another scenario is if the mother's viral load is not that high, but you have significant liver damage. How significant? We consider at least a stage 3 fibrosis. Now, regardless their viral load, regardless their risk to transmit the disease, I do recommend that you got a full entire pregnancy treatment for them because you don't want them to get worse during the pregnancy. So there are some requirement or some great benefits for significant damaged liver to get the treatment, regardless, whether they need for their baby or not.
Thank you. And then another question through the chats. In areas where both antiviral treatment and HBIG are options, what is the risk benefit to treating during pregnancy to reduce viral load versus waiting and only administering PrEP to baby? Pregnant women have asked this question and trying to decide what to do regarding starting treatment for hepatitis B during pregnancy.
You mean this is a hepatitis B monoinfection?
Yes.
And I'm still a little bit confused. So is it about using antiviral therapy versus using
just the HBIG and vaccination to the baby? It sounds like.
Well, if the viremia level is low, they're fine. They don't need to get any treatment, the mother. If less than 200,000, as I show you the slide number, I guess this is a slide. Let me share that. Still sharing, right?
Mm-hmm. Yes.
Can you see the slide? Mm-hmm. So here, this is the GRACE study looking at less than 200,000 IU, which is a 1 million copy. If you're below that, it's a zero infection. So the vaccine and HBIG is good enough. If you're less than that, you don't have to. But if mother have a viremia level higher level than 200,000 IU, you need triple, right? You need triple antiviral therapy, vaccine, and HBIG. Unless you want to skip the HBIG, but you need to start the antiviral early. Why? Because the viral kinemic study actually showing that in order to drop about 3 logs, you need at least 12 weeks, right? Now, without the HBIG, just like in E antigen negative patient, the safe threshold for viremia level is below 20,000, not 200,000. That's why you probably theoretically need a little bit longer time to make sure the mother's viremia level can drop. I prefer down to, 2 logs or even undetectable. So that's why the current approach is still using the third or mid-second trimester treatment triple prevention. In North America, triple prevention. But in the area that you don't have HBIG, then you should start earlier. Start the antiviral earlier. That's the idea that have been shown in the study we just done.
Great. Thank you. Laurie, does that answer your question?
Interestingly, there was another study done in Thailand, but not randomized. They started late. They started in the 3rd trimester without HBIG. They saw the breakthrough. And the idea is the later you start, the viremia level is still there, and it's not going to work well.
Thank you. That's helpful. Any other questions for Dr. Pan? All right. Great. Thank you so much.
I can tell you this group is very, very active, engaging, and all your questions surprised me. It's harder than what I'm answering in an international meeting.
Sorry. Yeah, we really got to it, to the details.
Right.
Really good conversation. So hope that
ready to shoot me down, right?
No, that was helpful. Thank you. Wonderful. Thank you so much. So now we'll turn it over to our case presentation, and Danica is going to be presenting on some of the work that the perinatal coordinating program in Philadelphia does on the ground, which will hopefully provide some